Welcome to the CGA-IGC podcast series, brought to you by CGA's Education Committee and made possible through the generous support of our sponsor, Lynch, formerly LS Cancer Diag. Each episode aims to bring you an in-depth discussion related to emerging data, clinical challenges, and unique perspectives in the world of hereditary GI cancers. Before we start, we'd like to remind you that the content of this podcast is not intended to replace professional medical advice, diagnosis, or treatment, and the content reflects expert opinion at the time of recording. Keep listening to find out more about this episode's host, guest, and featured topic. Also, be sure to learn more about our sponsor at lynsightlabs.com. That's LYNSIGHT labs.com.
Hi everyone, welcome to the CGA-IGC podcast. My name is Josh Sommovilla. I'm a colorectal surgeon at the Cleveland Clinic, and I'll be your host for this episode. During today's podcast, I'll be speaking with Paul Møller, a medical geneticist who initiated the prospective Lynch syndrome database. He recently published an article in the May 2024 issue of Hereditary Cancer in Clinical Practice entitled Incidences of Colorectal Adenomas and Cancers Under Colonoscopy Surveillance Suggest an Accelerated Big Bang Pathway to Colorectal Cancer in 3 of the 4 Lynch syndromes. Before we get into our discussion, I'm going to introduce my co-host and our guest. Co-hosting with me today is TJ Slavin. Dr. Slavin is a physician, scientist, and biotech executive, board certified in clinical genetics, molecular diagnostics, and pediatrics. He's the Chief Clinical Officer of Molecular Oncology at Quest Diagnostics. He previously held positions of Chief Medical Officer at Myriad Genetics and Chief Scientific Officer at Halo Precision Diagnostics. He was a former assistant professor in the departments of Molecular Oncology and Population Sciences at City of Hope National Medical Center and continues to help with their genomics education course. Paul Møller is our guest today. Paul is a medical geneticist who attained a PhD in multifactorial inheritance in HLA-associated diseases. He held the first Norwegian medical geneticist position for prenatal diagnostics in 1982. He established an outpatient genetic clinic at Norwegian Radium Hospital in Oslo in 1988, which he chaired until 2012. He has an extensive background in using deep computer programming to create and analyze the large volumes of data needed to process information and knowledge in multifactorially caused diseases. He played an active part in ICG-HMPC to find the MMR genes causing the Lynch syndromes. He's a co-founder of Insight and established, together with the European members of ICG-HMPCC, the Mallorca Group, later incorporated as the European Hereditary Tumor Group, or EHTG. He initiated the prospective Lynch syndrome database, a lot of which we'll be talking about today, in 2012. Later expanded to include international contributors, which he headed until 2023. He's a co-founder and honorary member of EHTG and author of over 300 international research papers. Paul, TJ, thank you for joining me. Dr. Møller, before we get into the details of your paper specifically, could you just please give us a little bit of a background into the PLSD, or Prospective Lynch Syndrome Database, the rationale for its formation, the types of questions it was designed for, and how the data is collected and used?
Yes, thank you for the invitation. The reason I designed PLSD as it is very simple. We all believed that colonoscopy could prevent colon cancer, but some 10 to 15 years ago, it was obvious that that was not so. We still saw colorectal cancers despite colonoscopy. We shortened the intervals between the colonoscopies, and we still saw colon cancers. So, to cite Hamlet, something was rotten in the state of colonoscopy. That is why I did it. And if you want to challenge an assumption, you have to make a database without ascertaining the cases based on the assumptions which you want to challenge. Otherwise, you will return your assumptions as the findings. And that, by the way, is the very problem of the gold standard of research, the hypothetical deductive method, because the only thing you do if you do an hypothesis deductive study is to try to verify one hypothesis, and you will never find anything else. So if we start with putting one argument aside, we all agree that an adenoma may develop into colorectal cancer, period. PLSD results and papers and myself and my closest have never, ever said we should stop colonoscopy. But we have said there is other things going on as well, and that's what I like to see. So PLSD is filing cancers as the cancer registries do, as discrete events in time, and time is the age of the patient. And there are 2 sexes. We agree that there are at least 4 genes in question which may cause cancer. And we possibly all agree that there are 13 organs which may have cancers. And then you have 19 variables. And if anybody, I can tell you if you want to know how many ways there are to put together 19 independent variables, it is 1 followed by 17 zeros. So you need an extremely large amount of data. You don't have in the world enough carriers to examine every possibility. The only thing you can do is to get together enough data to answer a few simple questions. That is what PLSD has been doing. And the power calculations was that I needed 25,000 prospective follow-up years to make anything out of it for a start. And when we had the start, I made the 3 first papers and said that was it. I'm old, I'm going to retire and pack my bags. And then the Mallorca group said, no, this is too good to be closed down. So I said, well, if you want to continue, I can continue to keep the database and computer results, but somebody has to write the papers. And you have possibly a lot of you met Mev and Tony, who have been first authoring a lot of papers since then. And that's about it. We have enough data to try to challenge some hypotheses on what's going on. And everything was very good. I was acquainted with everybody and everybody liked it very much until the results showed that colonoscopy did not reduce colorectal cancer incidence. I'm very grateful for the opportunity to try to discuss what we have seen and what it may mean. Thank you.
No, thank you. So the paper that we're discussing today, basically looking at the PLSLD data, your paper found that in patients with pathogenic variants in MLH1, MSH2, MSH6, that the patients who were found to have adenomas and did not have any increased cancer risk compared to the patients who did not. And you use some terms in your paper, one being the mean sojourn time, and the other being the carcinogenesis in Lynch syndrome being a stochastic causative process. Could you talk a little bit about what you mean by these terms and how it's borne out in the data of your paper?
Yes, I'm happy to do. And first, let's clean out the nomenclature. Healthy carriers are not patients. They are healthy. It is forbidden by European standard after what happened in the Second World War to denote any person abnormal based on genetic constitution. You are not allowed to do racial discrimination based on genetic inheritance. So, and the other is that if you all are familiar with the concept of the ether, because 100 years ago, we all agreed that light was a wave, but a wave cannot go anywhere in an empty space. A wave in the ocean needs the water to be a wave. So then they invented the concept of an ether. There was something in the empty space because otherwise the light from the sun could never reach the earth. Now, then Einstein and the other guys came along and said, no, light is a particle, it's a bullet. It can travel through an empty space. So if there is something there, it's actually hindered, it is not augmented. So the parallel is that what Henry Lynch described was that there is something called a colorectal cancer inherited syndrome, which is not a polyposis syndrome. And we called it HMPCC, hereditary not polyposis cancer. But then Fogelstein said there is to be an adenoma first, and then Jeremy Jess invented the idea of an accelerated process. So there is an adenoma, despite nobody has seen it and nobody will see it. It's just a fiction. Nobody has ever proved there always is an adenoma before a colorectal cancer. So I challenged that interpretation when it turned out that colonoscopy did not prevent colon cancer. And the more we did colonoscopy, the more cancer we found. Something else was going on. And the last paper out is the first where we looked into the adenomas, and we found the same as everything else. about a quarter perhaps of these patients have an adenoma or two, and there is no association between adenoma prevalence and cancer prevalence in the cases. So until somebody put up a better evidence than I possibly suggest for the PMS2 in that paper, there is no evidence at all for the accelerated adenoma carcinoma paradigm. It's a fiction trying to explain something which is obviously wrong.
So I guess putting that aside for a moment, if we accept that as the truth and that accelerated adenoma to carcinoma sequence is not something that we believe in or a reason to do.
Sorry, may I interrupt you?
Sure.
Nothing is the truth. Everything is observation, and the only truth is the empirical observation. How we interpret them may change. So that's my best interpretation at the moment. I'm not claiming it to be true.
Sure. So as a clinician, ultimately, something we've discussed has been, how do you take evidence and make clinical guidelines out of that? And so when trying to think about what to do clinically for people who have pathogenic variants in these genes, at some point we have to decide what the appropriate screening intervals should be. So if we were to accept that accelerated adenoma to carcinoma sequence is not a great reason for doing increased colonoscopy, some people would say, okay, early detection of cancers and early ability to treat cancers would be an acceptable reason to do that. Does the prospective Lynch syndrome database have any data to support or refute that reason for performing colonoscopies in these people?
This is an interesting question because PLSD has actually shown that. The problem was that we all set out to do the colonoscopies, believing to prevent cancers. And when that failed, then the PLSD results was interpreted as we're arguing that we should stop colonoscopy. To the very much contrary, we have proven that early diagnosis and the old way of treating it provides about 90% cure. But what we also have demonstrated, and that is together with what you call the three-country study, because between Finland, Germany, and Netherlands, is that there is no association between interval between colonoscopies and prevalence of incidences of colorectal cancer. So there is no proof whatsoever to me that colonoscopy more than every 3 years do anything good. What we do know, it has side effects. I have seen colon perforations and severely ill patients. So a dramatic story I remember very well is an older man having a colon perforation, become very ill, operated in spinal anesthesia, and when it's all over, they have cut off his ischiatic nerve. So something can go wrong.
You know, given the different causes of Lynch syndrome genetically, do you feel like 3 years would be across each of the genetic carrier types?
I have no feelings, but I see no evidence that is doing anything good. That's my, so I want to get out of the discussion in what I try to relate to facts. And I have not seen any facts that colonoscopy more frequent than every 3rd year is doing good, but I know it's doing harm.
Do you think that it's even worth investigating whether colonoscopy every 3 years compared to what we would do for average risk individuals would be beneficial? Or is that something because people with these genetic pathogenic variants have been followed with increased surveillance for so long that we just don't have data to compare them to even more spread out intervals?
The basic question is not the economic in doing it more frequent than 3 years, but it is the limited resources is not the money. The limitation is the manpower of specialists doing the colonoscopies. And I have suggested to UK, who is now doing national guidelines for every 2nd year, they could start with randomizing to every year and every 3rd year to get an answer to the question if more than every 3rd year is beneficial. It will just be a randomization process and cost nothing. But going beyond every 3 years is, of course, an ethical question, because you will at the moment get no society will advocate to do it less and identifying carriers and not doing the best you can would be a very tricky project. I wish you luck with if you try to persuade people to not get the best.
So back to discussing the pathogenesis of colorectal cancer in situations where there's MMR deficiency. Could you talk a little bit about the PLSD and its ability to collect data about MMR deficiency in adenomas that are removed, and whether this data would be helpful in kind of furthering the question that we've been talking about?
That's possibly my favorite question, because I have to start with the worldwide known allegory of Schrödinger's cat. It's alive, but when you open the door, you kill it and it's dead. So what will happen if you hadn't opened the door? What the cat would be doing, nobody knows, because you killed it. If you take out a tumor, you kill it. You have no idea what will happen to it if you have not taken it out. It is not possible to take a biopsy of the tumor, because as we know, a tumor may have many substrata with different properties. And you will not be allowed to have a possible cancer in a patient and don't cure it. So everything we say we know about the progression from adenomas to cancers is an assumption based on the adenoma-carcinoma theory, that there always is a preset succession of events, and that is not true. Mutations are random. They can occur in any gene, and it is demonstrated completely that the reason you cannot prevent ovarian cancer in BRCA carriers is that the mutation causing invasive growth may occur long before you have a mutation causing a proliferation of the tumor. So if you are philosophic and quantum mechanics, it is by definition not possible to describe any object without disturbing the object. And that psychiatrist knows very well. You cannot interview a patient for any psychological problem without intervening and changing the interview object's perception of what's going on. This is a general thing. So whatever we think we know about the adenoma-carcinoma progression are assumptions, and we are returning the assumption as a proof, but there's no proof. There's only assumptions.
Mm-hmm. Yeah, and in your paper, you talked about the accelerated stochastic pathway and some differences that you noted in PMS2. Do you mind elaborating a little bit there on the results of what you're finding?
Well, I was trying to be nice and not come in conflict with everybody believing in good old Jeremy Jess, which was so good looking that all the lady loved him. So I just tried to be nice and say, well, we possibly have a case for the accelerated theory, adenoma-carcinoma, and that may be PMS2. But the main bulk of cancers for the others seemingly not is caused this way. There is something completely, what we have learned not from PLSD alone, but from the biological studies, is that we think that in polyposis, the progression from adenomas to cancers are so fast, and they have so many adenomas that you have to remove the colon, right? Some of you are dealing with polyposis. Actually, the amylase-1 and MSH2 carriers has more MSI crypts than the polyposis patients have adenomas. And they have it for a much longer time, until only half of them get one cancer. So what we call the mean fusion time, the time from the first MSI cell until it becomes cancer, is extremely long. And that is probably not because of the mutations rate. It is most possibly because you have another opposing stochastic mechanism, and that is the host immune system.
Mm-hmm. Yeah.
You have two opposing mechanisms, and until you have sort of a way to describe them both simultaneously, it is not possible to understand what actually is going on. By the way, what the Insight Council did not accept to discuss was the possibility that the immune system could not only eradicate an MSI crypt, but also an MSI cancer. But immunotherapy have proved them wrong. We all know at the moment that the immune system can kill a cancer. You can, if you help it a little.
Mm-hmm.
Right?
And do you think that's stronger in the MLH1 carriers. You bring up also in the paper about the separate pathway of CT-NNB1 and MLH1.
Whether I have hacked up the Heidelberg group to discuss this, or if they have sort of approached me, I don't know. But we have discussed for years Schrödinger's cat, how to interpret what we see. So what is demonstrated by them and others is that the MLH1 carriers and the MSH2 carriers has about 1,000 MSI crypts in their gut at any time in adult life. So the probability for one such crypt to become a cancer is extremely low. And it's constantly invaded by the immune competent cell. And I know that these guys now are trying to produce vaccines against the cells, not only checkpoint blockers to help the immune system get rid of the MSI cells. So I think that is the most exciting things going on today.
Mm-hmm. Yeah.
But the bottom line is that because the immune system may remove established cancers, you can find more cancers the more you colonoscopy, because you find those who would be removed by the immune system as well. If you don't tell anybody, the problem is that if that is so, the survival of colon cancer when colonoscopy is not as good as reported by PLSD, because some of them, these cases had been cured by themselves. But that I have not put in print yet. That's destroying the glory of how good we are doing at the moment.
Yeah, I think it's just scary to me to think about a person who, whether or not, I appreciate your point. It's scary to imagine identifying a colon cancer and assuming that the immune system may take care of it and not having to do something else to treat it.
I didn't say that.
No, I'm not. I appreciate that, but to extrapolate from that and
No, that's the problem. I never meant it. I never said it. My problem is that NIH has put in the guidelines that because of the high incidence report colorectal cancer reported by PLSD, you have to start colonoscopy to reduce it. But PLSD results are the result of colonoscopy. And that is higher than anybody else has reported. So we don't know which cancer you could let go. We don't know, and you better take them out.
Given kind of what we've learned about these types of cancers and the carcinogenesis pathway, are there other non-colonoscopy methods that you think might be more effective in this population to screen and identify for colon cancers, such as non-invasive tests that could potentially detect the degree of MSI unstable crypts and things like that?
There's been a lot of attempts going on from the old days. We had Sideransky's, KRAS, and etc. in the old days. I lived a long life in this game, and I have learned a lot of attempts failing. The problem is I must return to you, because you are the one who are doing colonoscopy. So exactly what is colonoscopy? It's a non-defined method subjected to time frames. I cannot calculate on anything if you don't tell me what to calculate upon. So what you could do, of course, is to use a lot of money to do it very often in specialized centers, which, by the way, then you will deprive a lot of your population from health service, because you don't have all these specialists doing it. They will be doing that, and they won't help others. And when you have done so, you have all the side effects of colonoscopies. If you think that is a good way of living your life and doing this for some 10 to 20 years to get a result in 250,000 follow-up years, be my guest. I will possibly go for something else based on the facts we see today. You are smiling, but I'm serious. So the problem is the assumption that there is a precursor you can find and remove it. But remind you, you have 1,000 precursors in the gut at any time in the MLH1 and MSH2 carriers. So I don't think you are serious if you are going to do colectomy in all carriers in adolescence. Please don't.
Yeah, it's clear we have a lot to learn about the pathways, and we're failing as a society in some regards by still having patients who, many people probably listening to this have patients that they've been getting very frequent colonoscopies and still wound up getting a colon cancer, likely coming out of a crypt. So yeah, it's an area that needs a lot of focus for the Lynch syndrome community.
if you consider, I don't say it's truth, I don't say it's the only truth, but if you consider the probability that most cancers are caused by stochastic mutations, if you just consider that, it means that you can predict what will happen on group level, but you can never predict on a single patient. And it means that all the efforts to find modifying genes to increase or reduce penetrance is a misconception. And every doctor have learned by heart at medical school that you should never tell a patient exactly what his or her future is. It's random variation. And if you consider carcinogenesis as a continuous process, like we did in the past, please remind that it is driven by mutations, and mutations are not continuous processes. They are discrete events in a single moment in time, and there is no one having half a mutation. There is nothing such a half a mutated gene. You either have it or you don't have it. So this way of thinking that it is all a floating continuous process, as from everything we know, it is a misconception. It's all about stochastic processes. What we have not discussed is that a tumor is a population of very many cells with subgroups. And that population is subjected to genetic drift and selection of subgroups. Who is to survive and who is not to survive within the tumor. And if you change the environment, you will select another subgroup. So the best way of treating it is, of course, to take it all away. But if you make some chemotherapy, then you change the environment and the fitness of the internal subgroups, and you call it resistance to chemotherapy, because you will select a subclone. And that subclone may develop by stochastic processes. You don't have it for started, it developed down the road. Now we are going into hypothesis, how to, yes, this is not
I think
firm
there's a lot of
knowledge.
evidence supporting your theories there. So, and also, adding in the immune system to that whole discussion there, that's also acting somewhat in random.
From the perspective of the tumor, the immune system is an environmental property which must change the fitness of the individual tumor cells. And this is going very fast. It is possibly an extremely rapid balance all the time. And what is happening, a cancer is possibly caused when, if something by chance happens, and that was the last paper was about the Big Bang, because we know that there may be multiple mutations happening simultaneously in some cancer cells. All the cancer biologists know that in solid tumors, there may be very many. So if something happens, which the air pilots call, you're passing the time of no return. There is no return from this stage. That is possibly what we should look for in carcinogenesis. Not all this noise in what's not becoming a cancer, but what are the critical events from where there are no return. And that is not the initial drivers. The initial drivers is fooling around with the probabilities for something to happen. It is not determining what to happen exactly.
Well, I think before we wrap up here, I just wanted to give you a chance to talk about what you think the most important ways the PLSD can move forward in studying important research questions in Lynch syndrome in the future.
Well, you have possibly met both Mev and Tony, many of you. So my advice to them is to discuss with you all what is the most pressing answer you would like to get out of it, and then do power calculation. Then you have to decide what you need to put into the database to get that answer out. And then you do power calculation and see how many cases do you need to get an answer. And it's very disappointing how much we lack resources. And if you need more carriers into the equation, then there are inhabitants on the carriers on the Earth, then you're out of business. You have to select very carefully what you are looking for, if not doing a lot of work in vain. But the low-hanging fruit, of course, is that you are dealing with colorectal cancer, but most carriers are dying from cancers in other organs. And we lack the biological precise description of what's going on in these other organs and what you could do right up. And that's what PLSD has been calling for now already, is who has been treated with immunotherapy? Will that make a change in prognosis? And what about these late, infrequent, serious cancers? What about pancreatic cancer, bile duct cancer, brain cancer? You don't need large series. You can just treat them with immunotherapy and see if it works. But you need to collaborate, and PLSD is not owned by anyone but the contributors. So if you contribute to PLSD, you will own it together with the owner contributor. So my advice to you all is to join forces to get the answers, because nobody will get the answers alone. That's my
well said.
position.
Thank you. That's a great point. Paul, we just wanted to thank you for your time to discuss your paper today and for all that you've contributed to the information that we have about treating Lynch syndrome from the CGA community. Thank you very much. And this will conclude the CGA podcast.
Thank you. It was a pleasure. Thank you.